Hi, and welcome to the B-HIPP Briefs presentation on anxiety disorders. This video will cover the identification and assessment of anxiety disorders in pediatric primary care. My name is Dr. Aronica Cont'd, and I am a child and adolescent psychiatrist at the University of Maryland School of Medicine. In addition, I am a consultant with the Maryland B-HIPP program. Maryland Behavioral Health Integration and Pediatric Primary Care, or simply B-HIPP, is a program that provides support to pediatric primary care providers through free telephone consultation, training and educational opportunities, resource and referral networking, and in select sites, social work co-location. B-HIPP is supported by funding from the Department of Health and Mental Hygiene and the Maryland State Department of Education, and is executed through a collaboration between the University of Maryland School of Medicine, Johns Hopkins University, and Salisbury University. Here's a brief overview of what we will be covering in this B-HIPP brief presentation. Some facts. Affecting between 15 to 20% of youth, anxiety disorders are among the most prevalent psychiatric conditions in children and adolescents. Moreover, from a public health standpoint, these disorders, when present in youth, increase the risk of suicide attempts and are associated with significant morbidity and mortality. Additionally, longitudinal data suggests that anxiety disorders in youth predict a range of psychiatric disorders later in life, including other anxiety disorders, substance use disorders, and depression. Accumulating data from both retrospective and prospective studies suggests that anxiety disorders are both the most frequent psychiatric disorders in children and adolescents and represent the earliest form of all psychopathology. Mostly due to the frequent early emerging specific phobias, the onset of the first or any anxiety disorder is usually in childhood and thus considerably earlier than the onset of depressive or substance abuse disorders, as seen in Figure 1A. However, there is considerable heterogeneity in the onset of the specific anxiety disorders, with generalized anxiety disorder, agoraphobia, panic disorder, and obsessive compulsive disorder, mostly emerging in adolescence, or as seen in Figure 1B. Overall, anxiety disorders are more prevalent in girls compared to boys, although it is noteworthy that sex differences are accentuated by development, with prevalence ratios reaching 3:1 by adolescents. Although anxiety disorders with onset in childhood or adolescence may spontaneously remit, the course of pediatric anxiety disorders is overall considered to be chronic and persistent. The individual course, however, is often waxing and waning. The presence of a pure anxiety disorder decreases with age in favor of patterns with multiple anxiety disorders, and by late adolescence or early adulthood, secondary psychopathologies such as depressive or substance use disorders have frequently developed. Thus, early anxiety manifestations are at the outset of a cascade of psychopathology, suggesting the need for early recognition and treatment. And now a case example. Sarah is a 10-year-old girl who lives with her grandmother, mother, father, and younger sister. Recently, her father's brother came to live with the family after he moved to the city for work. She has always been somewhat of a shy child, never one to speak up much in class, but she has been a good student. Over the last few weeks, however, she has been sent home 3 times from school after saying that she had a pain in her chest and trouble breathing. The first time, her mother had taken her immediately to the doctor, who found nothing wrong. The second time, her mother just put her to bed, and by evening, she seemed fine. The third time, her mother was concerned that Sarah was simply trying to avoid schoolwork, but she has come for a visit because the school says that Sarah cannot return until a doctor says that her health is good. Children with anxiety disorders may present with fear or worry and may not recognize their fear as unreasonable. Commonly, they have somatic complaints of headache and stomachache. The crying, irritability, and angry outbursts that often accompany anxiety disorders in youth may be understood as oppositionality or disobedience. when in fact they represent the child's expression of fear or effort to avoid the anxiety-provoking stimulus at all costs. A specific diagnosis is determined by the context of these symptoms. If your patient has generalized anxiety disorder or GAD, he or she will worry excessively about a variety of things, such as grades, family issues, relationships with peers, and performance in sports. Children with GAD tend to be very hard on themselves and strive for perfection. They may also seek constant approval or reassurance from others. A panic attack is an abrupt onset of intense fear or discomfort that reaches a peak within minutes and includes at least 4 of the following symptoms: palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath, of smoldering. Panic disorder is diagnosed if your child suffers at least 2 unexpected panic or anxiety attacks, which means they come on suddenly for no reason, followed by at least 1 month of concern of having another attack, losing control, or going crazy. Separation anxiety disorder is most common in kids ages 7 to 9. When separation anxiety disorder occurs, a child experiences excessive anxiety away from home or when separated from parents or caregivers. Extreme homesickness and feelings of misery at not being with loved ones are common. Other symptoms include refusing to go to school, camp, or sleepover, and demanding that someone stay with them at bedtime. Children with separation anxiety commonly worry about bad things happening to their parents or caregivers, or may have a vague sense of something terrible occurring while they are apart. Social anxiety disorder, or social phobia, is characterized by an intense fear of social and performance situations and activities such as being called on in class or starting a conversation with a peer. Children who refuse to speak in situations where talking is expected or necessary to the extent that their refusal interferes with school and making friends may suffer from selective mutism. Children suffering from selective mutism may stand motionless and expressionless, turn their head, chew or twirl their hair, avoid eye contact, or withdraw into a corner to avoid talking. These children can be very talkative and display normal behaviors at home or in another place where they feel comfortable. Parents are sometimes surprised to learn from a teacher that their child refuses to speak at school. The average age of diagnosis is around 5 years old, or around the time a child enters school. Obsessive compulsive disorder, or OCD, is characterized by unwanted and intrusive thoughts, obsessions, and feelings compelled to repeatedly perform rituals and routines, compulsions, to try and ease anxiety. Most children with OCD are diagnosed around age 10, although the disorder can strike children as young as 2 or 3. Boys are more likely to develop OCD before puberty, while girls tend to develop it during adolescence. PTSD, or post-traumatic stress disorder, is an intense fear and anxiety, children who become emotionally numb or easily irritable or avoid places, people, or activities after experiencing or witnessing a traumatic or life-threatening event. Not every child who experiences or hears about a traumatic event will develop PTSD. It is normal to be fearful, sad, or apprehensive after such events, and many children will recover from these feelings in a short time. Children most at risk for PTSD are those who directly witnessed a traumatic event, who suffered directly, such as injury or the death of a parent, have mental health problems before the event, and who lack a strong support network. Violence at home also increases a child's risk of developing PTSD after a traumatic event. Several well-studied child self-report screening measures for anxiety exist and may be used in patients greater than 8 years old. First, the multidimensional anxiety scale for children, and the screen for child anxiety and related emotional disorders, and the Spence Children's Anxiety Scale were developed to be sensitive and specific for assessing anxiety in youth and are useful in clinical practice to monitor treatment progress. The Preschool Anxiety Scale, which is not shown, is a parent report adapted from the Spence Children's Anxiety Scale that was developed for screening for anxiety in young children, ages 2 to 6. The Scared and the Spence are available online and free. Second, The Pediatric Anxiety Rating Scale, which is frequently utilized as a primary or secondary outcome measure in psychopharmacologic trials of youth, is a clinician-rated measure used to assess the severity of anxiety symptoms and change over time. Third, with regard to social phobia or social anxiety, the Social Anxiety Scale, the Social Worries Questionnaire, and the Social Phobia Subscale of SCARED are brief screening measures for social phobia, social anxiety symptoms. Fourth, a set of novel dimensions anxiety scales were recently generated during the DSM revision process to support the clinical decision-making and monitoring treatment progress. These self-rated scales can be used for children ages 11 years old or older and comprise the core constructs of fear and anxiety together with cognitive, physical, and behavioral systems in a consistent and brief way, and can be found at that website. The SCARED tool is the scale recommended by the B-HIPP program and can be found under the Resources tab on the B-HIPP website. Some practitioners use the Generalized Anxiety Disorder 7-item scale, and while it is brief and easy to use in the outpatient setting, it only screens for generalized anxiety disorder. The SCARED consists of 41 items and 5 factors that parallel the DSM-5 classification of anxiety disorders. There is a child and a parent version, and they have moderate parent-child agreement and good internal consistency, test-retest reliability, and discriminant validity. The SCARED is an instrument that screens for a number of anxiety disorders as seen on the slide and include generalized anxiety disorder, separation anxiety disorder, panic disorder, social phobia, and in addition, if these symptoms relate to a school phobia. So, as a primary care physician, if you were to make a call to B-HIPP, this is the process that typically takes place. B-HIPP provides phone consultation for primary care physicians with child mental health specialists, child psychiatrists, psychologists, clinical social workers, and licensed professional counselors at the University of Maryland School of Medicine and Johns Hopkins. Consultation is available Monday through Friday, 9 to 5, and all inquiries are responded to within 1 business day. The team is available to provide consultation in many areas of behavioral health, including medication management, diagnostic issues, developmental delays, school learning issues, autism spectrum disorders, adverse child experiences, and early childhood mental health, ages birth to 5 years old. B-HIPP also provides continuing education and training opportunities to help expand the knowledge and the skill base of pediatric primary care providers in mental health. And B-HIPP also has a comprehensive database of services across the state to be able to provide to primary health care providers to help guide their patients to resources that might be available in their area. These are some of the references used to create this talk. And as always, if you're a primary care provider and you need support to identify, assess, or manage an anxiety disorder, or if you need assistance with locating resources or referrals in your community, please give us a call. The B-HIPP consultation warm line is open Monday through Fridays, again, 9 to 5, and all you have to do is call 855-MD-B-HIPP. That's 855-632-4477, and we look forward to hearing from you.